This is a case of Monteggia and Galeazzi fractures. In this instructional video, I will go through the vignette provided for you in the case module, show you an approach to elbow radiograph interpretation. We will apply it to the images provided for you, and then we'll go through the post-module questions together. An 8-year-old female presents to the emergency department after falling off a trampoline. Her friend tried to stop her from falling and pulled on her arm. The patient then felt immediate pain in the forearm. She was otherwise healthy and is not on any medications. Family and social histories are non-contributory. On physical examination, you notice soft tissue swelling, most pronounced in the proximal forearm. Further examination is limited by patient discomfort. So this is one approach to ankle radiograph interpretation. I'm showing you the ABCs mnemonic because it can be easier to remember when you're starting out. Different people will have different approaches to interpretation. It's just important that you're consistent and systematic so that you don't miss a pathology. So the A stands for alignment, and that's when you can draw the anterior humeral line and the radiocapitellar line. And I'll go through those with you shortly and show you what those mean. Next, you want to trace the cortex of the osseous structures that you see on radiograph to look for any cortical disruption that could suggest fracture. Alternatively, you could find an osseous mass that could be either benign or malignant. C stands for cartilage or effusion, and that's where the anterior and posterior elbow fat pads come into consideration, which I'll also go through with you shortly. And lastly, you have soft tissues / everything else, where you can look for any abnormal soft tissue masses or calcification, or even soft tissue edema. Having soft tissue edema in a region can actually raise your suspicion of a possible fracture and tell you to scrutinize that area more closely. So in terms of alignment, you would draw these two lines on the ankle radiograph, on the lateral elbow radiograph rather. So when we draw a line down the anterior part of the humerus, it should intersect within the middle third of the capitellum here. Next, we have the radiocapitellar line, which, if you draw it from the middle of the radius, it should intersect the capitellum here. If any of these lines are out of alignment, consider radial head dislocation. This is an example of a Sale sign, which has to do with the anterior and posterior elbow fat pads. Seeing an anterior fat pad is not necessarily pathologic, but when it's displaced and bowed outward like you can see here, then that would be indicative of a pathology. Seeing the posterior fat pad, on the other hand, is always pathologic. And if you can convince yourself, if we trace this posterior and anterior fat pad, they are kind of bowing like a sail, and that's why we call it a Sale sign. When you see this sign, think a radial head fracture in adults. Or it can be indicative of intra-articular trauma. Next, I'll show you an approach to wrist radiograph interpretation because the images provided for you in the case file are forearm radiographs, and therefore you would want to assess both the elbow and the wrist region. So we'll go through the ABCs again. We have alignment, which involves the radiocarpal joint. This should cup these carpals nicely, and the most distal articular part of the radiocarpal joint should be the radial styloid over here. Next, you have Gilula's lines, which are the carpal arcs, which should form 3 smooth uninterrupted arcs. You should see a lazy M appearance to these carpo-metacarpal joints. You want to make sure that the distal radio-ulnar joint is articulating properly. And you can also assess for something called ulnar variance. the ulna can either be longer or shorter than the radius. If you have a positive ulnar variance, it means that the ulna is longer than the radius. And that can predispose somebody to ulnar impaction of the lunate and can lead to early degenerative changes of the lunate here. You can also assess for the scapholunate interval to look for widening. And lastly, approximately 2/3 of the proximal cortex of the lunate should be articulating with the distal radius here. B stands for bones. Again, you'll want to trace the cortices of all the bones that you can see on the radiograph to look for any cortical disruption or abnormal masses. Cartilage or effusion, and that kind of ties into the scaphoid fat stripe or the pronator quadratus fat stripe. If you notice any abnormal displacement of these stripes, it suggests effusion and can be a sign of either a subtle or radiographically occult fracture. In particular, the scaphoid fat stripe can be important because oftentimes scaphoid fractures will not declare themselves immediately on presentation. And again, you want to assess the soft tissues for any abnormal masses or calcification. Look for soft tissue edema that can guide your eye towards an area to look more carefully at. And just remember, the point is to be systematic. On the lateral radiograph here, we want to see the radius and ulna nicely aligned. We don't want to see any dorsal tilt to the radius. And if we draw a line from the radius, it should intersect the lunate and the capitate up here, which we can see on this example radiograph that it does. So let's apply our approach to the forearm radiographs that we were provided. So when we're assessing for alignment, the first thing that catches my eye is that the radial head is not articulating properly with this capitellum. And on the lateral radiograph, if we draw our anterior humeral line, we notice that it's not intersecting with the capitellum at all. And the same thing when we trace the radiocapitellar line. There is no intersection. So what this is suggestive of is radial head dislocation. As we trace the cortex of our bones, we can notice this cortical disruption here in the shaft of the proximal ulna. You can appreciate it much better on the lateral radiograph, which is why it's always important to have orthogonal views, so an AP and a lateral, especially in the context of a trauma. Next, we could look for the Sale sign. I'm not seeing any abnormal bowing of the anterior fat pad. I'm not seeing the posterior fat pad at all. If this was a dedicated elbow radiograph, we might be able to see it, but as such, at this time, we aren't. And when we examine the soft tissues, we notice this area of increased density here, and this is indicative of soft tissue edema. So again, if something in the ulna here is more subtle, this soft tissue edema could raise your suspicion to scrutinize this area more closely. So let's go through the questions together now. So where is the fracture located? Now this is simply an example so I can explicitly show you the different parts of a long bone. This question does not have to do with this distal radius and ulna. It has to do with the prior radiographs that we saw. And the fracture was in the proximal ulnar diaphysis. So a long bone will have the diaphysis or shaft, and then you have the metaphysis, which is considered the neck of a long bone and connects to the physis, which we can see here in this skeletally immature patient, this lucent line. In adults, this plate will fuse and no longer be visible. And lastly, we have the end of a long bone, which is the epiphysis. So we know that the distal ulnar diaphysis is incorrect because the fracture is in the proximal ulna. We know that there is no fracture of the distal radius. And when we think back to our radiograph, we know that it's in the shaft of the ulna, which is the diaphysis, and therefore it was not at the end of the bone or epiphysis. Next question is, what other abnormality could we appreciate radiographically? We already spoke about this when going through our systematic interpretation. We know that the anterior humeral line and the radiocapitellar line were not intersecting the capitellum, which leads us to believe that there is a radial head dislocation, which means that A is the correct answer. There was no appreciable fracture of the medial epicondyle, and a Colles fracture is an eponym given to a very common extraarticular fracture of the metaphysis of the distal radius that results in impaction and dorsal angulation of the distal fracture fragment, and that is a finding that is commonly found after a patient has fallen on outstretched hands, also known as a Foosh injury, F-O-O-S-H. So question 3 is, what is the eponym for the imaging findings above? So we have a fracture of the proximal ulnar diaphysis with associated dislocation of the radial head. And the eponym for that is D, a Monteggia fracture. A Maisonneuve fracture involves an unstable ankle injury where you have either a fracture of the medial malleolus resulting in widening of the medial clear space, widening or rupture of the distal tibiofibular syndesmosis, and an associated fracture of the proximal fibula. So we know that A is not correct. A Sagan fracture is a avulsion fracture of the lateral tibial plateau. And lastly, a Galeazzi fracture is when there is a fracture of the distal radius with disruption of the distal radial ulnar joint. So we know that that also is not consistent with our imaging findings on the right. Finally, the last question is, what if you open the patient's imaging file and saw these images rather than the ones that we initially interpreted? What would be the eponym for these findings? So as we spoke about, if we're assessing for abnormal alignment, we notice the distal radial ulnar joint is not in appropriate articulation. Normally the ulna is sitting against the sigmoid notch of the distal radius, so the fact that this is extending beyond leads us to believe that there is a lack of appropriate alignment. Additionally, there may be some widening of the scapholunate interval, and the entire cortex of the proximal lunate is overlapping with the distal radius, which, when we trace the cortex of our bones, we can appreciate a significant fracture of the distal radial diaphysis, resulting in the radius translating towards the ulna, which is why we're seeing a disruption of the distal radial ulnar joint and all of this overlap with the lunate here. So, in summary, we have a fracture of the distal radius with disruption of the distal radial ulnar joint. The eponym for that is Galeazzi. We know from doing this case module together that it's not B, the Monteggia fracture. A T-low fracture is a traumatic ankle injury in the pediatric population, characterized by a fracture of the anterolateral distal tibia epiphysis. And lastly, D, a Bankart lesion, is incorrect because that involves a fracture to the antero-inferior aspect of the glenoid labral complex in the shoulder, and this is a common injury that we see after an anterior shoulder dislocation. This is a diagrammatic example of how the ulna typically articulates with the sigmoid notch here. And we can see how this is not articulating well at all. So that's how we know that there is disruption of the distal radial ulnar joint and a fracture of the distal radius. Sometimes a mnemonic people use to help remember the difference between Monteggia and Galeazzi fractures is MUGGER. So M stands for Monteggia. You have a fracture of the ulna, which is the U, and with Galeazzi here, which is the G, we have a fracture of the radius. And that concludes our presentation on Monteggia and Galeazzi fractures.